I think we'll only have lutetium when uh, there's a clinical trial that's currently up and running. I don't think your group are involved, Per, in enrolling patients for this trial, but I know the person who's sort of run this out is run by the group in Rotterdam. They're not recruiting patients into the trial in Rotterdam. Otherwise, you would have been sent over to Rotterdam. Some of you would have been requested anyhow that some of you go for that because it's a very worthwhile clinical trial. So what they're doing is they're comparing the lutetium treatment to standard treatment with octreotide in a subgroup of patients. And if that trial shows that the results are beneficial, I think that the authorities in many countries who have been reluctant to take lutetium and other forms of radioactive therapy on board will then be pushed into it. And I think it will also help us enormously to encourage the authorities to back that. And I think that's an important aspect of it. If we didn't have this trial going on, I mean, it is possible to try to get lutetium here. We're all convinced that it's a valid treatment. It's a little bit early overall, but I think that with this trial, I think it'll be better, and I think it will be. The answer to your question is I don't know how long, but we'll do our damnedest to get it, especially if it's proven positive in this clinical trial. Per?
Well, we have a lutetium, as you know, in Uppsala and also in other places in Sweden, but all patients are within a trial. That's how we have to deal with it. So we also will have our results presented in a while, and if they are positive, that will make it possible for also others to start conventional treatment without just having every patient in a trial.
The answer to that already is, I think it's valid, personally. I think some of my colleagues would also agree. And it's valid because, number one, with certain patients here who, as I mentioned, the people with the carcinoid syndrome type patients especially, where some of the other forms of therapy like chemotherapy is not as good, that it certainly is valid under those circumstances. And I think that we haven't been referring patients to another centre outside of Ireland, not because we don't have anything else. We do have other stuff, and we can do it as a holding method and all the rest of it. But we've been referring patients because we think it's a valid option. And by enrolling you in clinical trials in Uppsala or in Rotterdam or in other places, that is helping the overall European community and forwarding and advancing the whole thing. So the answer is, it is valid. I'm convinced of it. We've got to be able to put it into the proper hierarchy. And I think that, another way of answering that gentleman's question, which is a very good question, was, if it's not available to us and if it's not supported and we don't have the money or whatever like that, we'll still be providing that therapy. And I think we'll be providing it even easier or in a more easier way if when it's validated in clinical trial. And I think it probably will be validated. I'm convinced of that. Derek, would you like to?
I'd absolutely agree. I think the difficulty that we have sometimes is there has to be very good evidence to give a certain treatment. It has to be compared against the standard of care, and that's what's called level 1 evidence. Sometimes in rarer diseases like neuroendocrine tumours, it's very hard to do such studies because, number one, the disease is very rare, and number two, it can take a long time to prove that it actually works because the disease, as Dermot alluded to on his slides, in a lot of cases it's indolent. It goes on for years. So I'm personally convinced that this radioactive therapy works, and there's a lot of data from Uppsala, from the Erasmus in Rotterdam, and from other institutions in the UK and other places in Europe. I'm convinced it works, but the international community needs level 1 evidence to absolutely prove it works, and that's scientific evidence. So that's why this trial is being done, and we should have results from that trial soon. But even in the absence of the trial, many of us here are personally convinced that it does work, and if the treatment, if we feel it's appropriate, you will get access to it and you will be referred for it. And I think there's many people in the audience who've had the treatment, not just once, twice, but a number of occasions.
I just want to also stress, though, there is a bias in this room, and I mentioned it this morning in discussing it, but the people sometimes who come to this meeting are also motivated by the fact that they've had to go abroad for therapy as well. And I think you're a motivated group and a very highly educated group as well. but it does represent not a minority, but a subgroup of you with neuroendocrine tumors. So a lot of the patients, for example, that we see in our neuroendocrine tumor group, not a lot, but the majority, in fact, do not require a radioactive substance like that as certainly as a first-line therapy. So we've got effective other therapies, and also, it's not just used for patients who have got intestinal neuroendocrine tumors with this carcinoid syndrome, that type, because you can use it for other patients as well with pancreatic lesions as well. But we've got other therapies that are available, and it's also knowing which one to start with, because I showed you on my slide we've got I don't think we can say we've got a plethora. We've got quite a few active molecules and compounds and different ways of treating you, and sometimes this knowing which one to start with also is complexing for us. So how we get the sequence right, and some of you will have different forms of therapy, and even sometimes you'll have combined therapies like somatostatin analogs like the lanreotide or the sandostatin injection, and you're getting something else in addition to that. So getting the sequence right is something that's not answered, and this clinical trial won't give us that answer either. But there will be certainly groups looking at that as well. So it's but just to stress that for patients who haven't, for example, been referred to have PRT or lutetium, the vast majority of times that you don't have to, but it's not indicated. Okay, so it's for a subgroup of you and other patients.